Welcome back to the Deep Dive. Today, we're really diving into something that's just moving incredibly fast, AI in healthcare.
It's hard to keep up, isn't it?
Totally. I mean, you see the headlines, you hear the buzz.
Yeah.
The FDA alone recently approved an astonishing 191 new AI-enabled medical devices.
Wow, 191.
Yeah, bringing the total to over 880 as of, I think, May 2024. And these aren't small tweaks, They're really changing fields like radiology, cardiology, neurology.
The promise there is just huge. Imagine sifting through mountains of patient data instantly, getting truly personalized care.
Making diagnoses faster, maybe more accurately. It sounds incredible.
It does. It sounds revolutionary. But, and this is the big but we need to explore, as we rush to bring these tools in, there's this critical hidden danger.
Bias.
Bias.
Right, that's the core of it today.
Exactly, because these advanced models, these deep learning systems, they're powerful, but they're often what we call black boxes.
Meaning we can't quite see how they reach their conclusions.
Pretty much. We don't always understand the why behind their predictions. And that lack of transparency, well, it limits our ability to oversee them properly.
And opens the door for unfairness.
It opens the door to potential inequities, quietly shaping patient outcomes in ways we might not even spot, let alone fix.
Which is exactly why we're doing this deep dive. Our mission today is to really unpack how bias can sort of seep into healthcare AI.
At every stage, right?
At every single stage, from the initial spark of an idea.
All the way to how it's used every day in the clinic.
Exactly. We need to look at where these biases come from, what they actually look like in practice, and crucially, what we can actually do about them.
To stop them making existing health disparities even worse.
Right, and it's so important to understand this isn't just about, like, technical glitches or bugs in the code.
No, it's more fundamental.
It's about the core principles: fairness, equity, equality, and healthcare. We'll touch on the differences between those two, because sometimes a one-size-fits-all approach to fairness in AI, it can actually backfire. Okay, so where do we start this journey? How do we get a handle on where bias gets, baked in?
Let's picture the whole life cycle of a typical AI model. It's helpful to think of it in, say, 6 phases.
6 phases. Okay.
Yeah. From conception, the initial idea,
right,
through data collection, then pre-processing the data.
Cleaning it up, getting it ready.
Exactly. Then in processing, that's where the actual algorithm development and validation happens.
The coding and testing bit.
Then post-processing, which is really about clinical deployment, getting it out there.
Into hospitals, clinics.
And finally, post-deployment surveillance, keeping an eye on it long after it's launched.
So conception, data collection, pre-processing, in-processing, post-processing, surveillance.
Got it. And what's kind of startling is that bias can sneak in at any of those points. It's not just one weak link.
It's that classic bias in, bias out idea then.
Absolutely. If the input is flawed, the output reflects that. And maybe the most surprising place it begins is before any data is even touched. It starts with us, humans. Okay. That's where it gets really fascinating, isn't it? Because you instinctively think, well, AI, it's computers, it's data, it must be objective.
That's the common assumption. But often, the main sources of bias are actually human.
And it's not usually malicious, right? People aren't deliberately building biased AI.
Rarely deliberate, no. It's more subtle. It's our history, our perceptions, assumptions, even subconscious thoughts. They can all get embedded. The AI becomes a mirror.
Reflecting our own blind spots, maybe amplifying them.
Exactly. Amplifying them at scale. The real challenge is just acknowledging that AI isn't some pure, unbiased thing. It's built by people, using data from people.
So it inherits our messiness, basically.
Our complexities, yeah. Let's look at a few ways this happens. First, there's implicit bias.
Okay, the subconscious stuff.
Right. Those attitudes or stereotypes we hold without even realizing it. For example, studies have shown women with cirrhosis who are waiting for liver transplants, they're less likely to get one and more likely to die than men.
What? Or think about how women having a heart attack are sometimes misdiagnosed because their symptoms might present differently, atypically.
And if AI learns from data reflecting those patterns,
it learns the same biases. It perpetuates those blind spots, potentially making them seem objective because, well, the computer said so.
So it goes beyond just individual clinicians' subconscious biases.
It does. That brings us to systemic bias. This isn't just in our heads, it's built into the structures around us.
Like institutional rules or policies.
Exactly, or even funding disparities. Think about how, say, inadequate medical funding for uninsured or minority groups might lead to less data or different kinds of data being generated for those groups.
So the whole system creates biased data from the outset.
Precisely. Implicit bias might be one doctor's assumption, but systemic bias is like it's in the foundations of the building.
Okay. What else?
We also have to watch out for confirmation bias.
Where we look for evidence that proves what we already think.
You got it. Model developers, maybe consciously, maybe not, might select or interpret data in a way that confirms their existing beliefs. They might emphasize certain patterns, ignore others.
Can you give an example of that in AI?
Yeah, there were dermatology AI studies where this thing called annotation bias happened. Basically, how skin conditions were labeled in the training images was inconsistent, especially for different skin tones.
Because the people labeling were maybe reinforcing their own assumptions about how diseases look on different skin.
That seems to be a factor. They were teaching the AI based on potentially narrow or biased pre-existing beliefs.
That's powerful. And you mentioned something about older data causing problems now.
Right, that's concept shift, or sometimes called training serving skew. Basically, society changes, medicine changes, our understanding evolves.
But the old data doesn't?
Exactly. Old data sets might reflect past biases, maybe around ethnicity, for instance, that we now recognize as harmful. If an AI trained on that old data isn't updated, it can reintroduce those biases into modern care.
So it makes predictions based on outdated biased views.
Yeah. A concrete example is the shift from ICD-9 to ICD-10 codes. Those are the medical diagnosis codes. When that switch happened, there was a jump in identified opioid-related hospital stays.
Not because more people were suddenly using opioids?
Not necessarily, but because clinicians' perceptions and how they coded things changed with the new system. The meaning of the data shifted. If your AI doesn't keep up with those shifts.
It falls behind, making potentially harmful decisions. Okay, so the human element casts a really long shadow. But what about the data itself, once we start collecting it?
The data itself can absolutely be a source of bias. A big one is representation bias.
Meaning the data doesn't reflect everyone.
Exactly. A lack of diversity in the training data. If the AI simply doesn't see enough examples of certain groups, certain demographics, certain conditions in those demographics, it just won't perform well for them.
Like it hasn't learned about them properly.
Precisely. We've seen this clearly. Those image analyzing AIs, CNNs.
Right, convolutional neural networks.
Yeah. Trained on chest x-rays, they've been shown to underdetect diseases in specific groups. Females, Black patients, Hispanic patients, people from lower socioeconomic backgrounds.
Because the training set was maybe mostly from other groups?
Often, yes. Or think about skin cancer detection AI. Models trained without enough diversity in skin types perform significantly worse on darker skin tones.
It's a direct result of what it was or wasn't shown.
Absolutely. Then there's selection bias or sampling bias. This is about how the data is collected. The process itself might favor certain groups.
How so?
Well, take the UK Biobank, a huge health data resource. Studies found a healthy volunteer bias. The people who participated tended to be healthier, on average, than the general population.
So the data isn't truly representative of everyone the healthcare system treats.
Right. It's skewed from the start. And another subtle one is measurement bias.
Measurement bias.
Yeah.
How did that work?
Okay, so data often comes from different places, right? Different hospitals, different clinics. They might use different equipment, different software, different procedures for collecting the same type of data.
Like different MRI machines or X-ray setups.
Exactly. Those variations aren't biological differences in the patients. They're systematic differences introduced by the technology or the process.
So the AI might learn those quirks.
It can inadvertently learn patterns linked to, say, a specific brand of scanner or a particular software version rather than the actual medical condition. In radiology, this is huge. Hardware, software, acquisition settings all change image characteristics.
So it thinks it's detecting disease, but it's actually detecting the machine it came from.
Potentially, yes. It learns non-biological patterns.
Okay, that's a critical point. So we've got human bias, data bias. What happens when we actually start building the algorithm? Can the process of coding and training itself add more bias?
Yes, it definitely can. During the development, we can run into things like aggregation bias.
Aggregation, like grouping things together.
Yeah, combining distinct groups inappropriately. Maybe during data cleaning or preparation, you treat everyone the same way, creating a sort of one-size-fits-all model that's really optimized for the majority group.
But ignores the nuances of smaller groups.
Exactly. Imagine you're dealing with missing patient weight data. Maybe that data is more often missing for patients with certain disabilities, like wheelchair users or people with amputations.
Right, weighing might be difficult or less common.
So if you just, say, fill in the average weight for everyone with missing data, your model assumes a uniformity that doesn't exist, potentially disadvantaging those groups.
Okay, and what about choosing which data points the algorithm uses?
That's feature selection bias. Here, developers might intentionally include or exclude certain variables, maybe based on their own ideas about what's important.
Like deciding whether to include race or sex.
Exactly. Those are often called sensitive variables. Sometimes they're included as proxy variables with the intention of improving accuracy or equity. Like, including sex might prevent a model from predicting prostate cancer in a female patient.
That seems logical on the surface.
Hmm.
But you mentioned proxy variables before. Can using them actually backfire? Can it propagate bias instead of fixing it?
It absolutely can. And this brings us to a really important, quite famous study by Obermeyer and colleagues.
Okay, what did they find?
They looked at a widely used AI algorithm in the US that was designed to predict which patients needed more healthcare resources, like care management programs.
And how did it predict that? What was the input?
Here's the key. It used healthcare costs as a proxy for healthcare need. The assumption was higher spending means sicker patient.
Okay. I can already see a potential problem there.
Right. What they found was that this algorithm systematically underestimated the healthcare needs of Black patients.
Why?
Because historically, Black communities in the U.S. have often faced barriers to accessing care, leading to lower healthcare spending on average, even for people with the same level of illness.
So the algorithm saw lower spending and thought, oh, these patients aren't as sick.
Exactly. It mistook lower spending, due to systemic issues, for lower illness severity. The study found that at the same risk score generated by the algorithm, Black patients actually had significantly more chronic illnesses, about 26% more than white patients.
That's staggering. The proxy was completely misleading.
Completely. But here's the crucial part. When they recalibrated the algorithm, when they changed it to predict need based on direct health indicators, like the actual number of chronic conditions someone had, instead of cost,
What happened?
it nearly tripled the enrollment of high-risk Black patients into those extra care management programs.
Wow. Just changing that one input variable had that much impact.
It highlights just how profoundly the choice of proxy variables can embed and perpetuate systemic inequities. It wasn't malice. It was a flawed assumption baked into the code.
That Obermeyer study is a powerful lesson. Okay, so we've got the idea, the data, the algorithm, but the AI isn't finished yet. It has to be used in the real world, right? In clinics, hospitals. What happens then? Does human interaction fix things, or can it introduce yet another layer of bias?
It's definitely another critical stage, and yes, interaction can introduce new problems. Even with a seemingly well-designed model, bias can emerge in deployment.
Wow.
A big one is automation bias. This is basically over-reliance on the AI.
Just trusting the machine too much.
Yeah. It can show up in a couple of ways. Omission errors. That's when clinicians miss or ignore mistakes the AI makes, maybe because they're busy, or they just assume the AI is right. Think fast-paced radiology readings.
Okay, and the other way.
Commission errors. This is when clinicians actively follow the AI suggestion, even if it contradicts their own judgment or other evidence. They inappropriately trust the AI.
Is there evidence of this happening?
Oh, yes. A really striking example comes from mammography screening. Radiologists were shown mammograms along with AI suggestions for the BI-URAID score. That's a cancer risk score.
Okay.
When the AI gave incorrect suggestions, the radiologist's accuracy plummeted. For less experienced radiologists, accuracy dropped from nearly 80% down to about 20%.
20%, that's huge.
It is. And even for very experienced radiologists, their accuracy fell from over 82% down to about 45% when influenced by bad AI advice.
That just shows how powerful that automation bias pull is.
It's incredibly strong. Then, related to this, is feedback loop bias.
How does that work?
Well, imagine clinicians consistently accept the AI's recommendations, maybe due to automation bias, even if some recommendations are subtly wrong or biased.
Yeah.
Those accepted recommendations often get fed back into the system. They become part of the data used for future updates or retraining of the AI.
So the AI's mistakes get reinforced.
Exactly. The bias gets locked in and potentially amplified over time. There was a study with a model called Coronet for predicting COVID-19 admission needs. It was actually designed to sometimes give wrong advice, specifically to test if clinicians would override it.
Did they?
Only about 35 to 52% of the time, a lot of the incorrect advice was just accepted, creating a potential feedback loop.
So we can trust it too much. Is there a risk of not trusting it enough?
Yes, that's the other side of the coin. Dismissal bias, often called alert fatigue.
Like getting too many notifications and starting to ignore them.
Precisely. If an AI system generates a lot of alerts, especially false positives, warnings that turn out to be nothing, users can start to tune them out. They overlook or devalue the AI's input.
Can you give an example there?
Sure. An observational study in intensive care units, ICUs, looked at monitor alarms. They found over 2.5 million alarms. Almost 90% were for heart rhythm issues, arrhythmias.
Okay, that sounds important.
But the majority of those were false positives. So what happens? Staff get overwhelmed, they start routinely ignoring alarms, potentially missing a real critical warning amidst all the noise.
So it's this paradox. Rely too much, and you miss AI errors or follow bad advice. Rely too little, and you miss genuine insights.
It's a really tricky balance in human-AI interaction.
Okay, this feels a bit overwhelming. Bias creeping in everywhere, from our minds to the data to the code to how we use it. So what does this all mean for actually fixing it? It sounds like it needs constant vigilance.
It absolutely does. It's not a one-and-done fix. Bias mitigation has to be a continuous, dynamic process woven through that entire life cycle we talked about.
And whose job is it? The developers. The hospitals.
Honestly, it's a societal responsibility. AI developers, healthcare providers, institutions, even patients to some extent. Everyone has a role.
Okay, so let's walk back through those phases. What can we do at the very beginning at conception?
Right at the start, it's crucial to begin with a clear, clinically grounded research question. And critically, form a diverse and representative AI healthcare team.
Not just data scientists.
No, you need clinical experts, data scientists, hospital administrators or stakeholders, ethicists, and importantly, members of the patient populations the AI is intended to serve, especially underrepresented groups.
To bring those different perspectives in from day one.
Exactly. This team needs to consciously embed diversity, equity, and inclusion DEI principles right from the outset. Actively work to identify and counter potential, implicit, systemic, or confirmation biases in the whole design of the model and its intended use.
Okay, build a diverse team, focus on DEI from the start. What about data collection?
The goal here is straightforward but hard. Generate data sets that genuinely mirror the diversity of the population you want the AI to help.
How do you even do that?
It means using multiple data sources, maybe participating in collaborative efforts like open science initiatives or consortia like Standing Together, which focuses on data standards. It involves making conscious choices about using old retrospective data versus collecting new prospective data specifically for the task.
What are the hurdles there?
Oh, plenty. Data for underrepresented groups might just be scarce. That's data sparsity. Eliminating participation bias, like that healthy volunteer effect, is tough. And standardizing data collection across different sites takes a lot of resources. It's challenging, but vital.
Okay. Then we get to pre-processing, cleaning the data. What's key there?
This is where you handle things like missing data points, select the most relevant variables or features, and maybe do some feature engineering to try and maximize demographic representation without introducing new bias.
So being really careful about how you handle those gaps or select features.
Exactly. Because even seemingly neutral choices here, like how you fill in missing values, can inadvertently amplify bias if you're not careful. It's a delicate balancing act.
Right. Now, the core in processing.
Yeah.
Building and testing the algorithm itself. What tools do we have here?
We have several techniques. To tackle class imbalance, where you have way more data from one group than another, you can use methods like resampling.
Like duplicating data from the smaller group or removing data from the larger one?
Sort of, yeah. Or generating synthetic data, creating artificial but realistic data points for the underrepresented group using techniques like SEMOT, or you can use cost-sensitive learning.
What's that?
That tells the algorithm to pay more attention to mistakes it makes on the minority class, penalizing those errors more heavily during training.
To force it to learn better for that group.
Right. We also need to measure fairness using quantitative fairness metrics. Things like demographic parity, equal opportunity, equalized odds. These are mathematical ways to check if the model is performing equitably across different groups.
But you mentioned a trade-off.
Yes, the fairness-accuracy trade-off. Sometimes tweaking an algorithm to be fairer across groups might slightly lower its overall accuracy on the whole data set. That requires really careful thought about the clinical context and what kind of errors are more acceptable.
And what about those black boxes? Can we make them more transparent?
That's where explainability techniques come in. Tools like Lime or Eship try to help us understand which features were most important for a specific prediction, even in complex models.
So we can peek inside a bit.
Yeah, but with a caution. These tools aren't perfect. They can sometimes be inconsistent or oversimplify things. Generally, it's good practice to try and minimize model complexity where possible and choose architectures that are inherently more transparent.
And testing, validation.
Crucial. External validation is non-negotiable. You have to test the model rigorously in different hospitals with diverse patient groups across various clinical settings, especially if it's going to be used widely. Don't just test it where it was built.
Okay, so the model's built and validated. What about post-processing when it gets deployed clinically?
Here, strategies like human-in-the-loop, HITL, are key. That means having human experts review or interact with the model's outputs before they directly influence patient care.
Adding that human check back in.
Exactly. Also, transparency is vital. Disclosing the demographics of the population the model was trained on helps clinicians decide if it's appropriate for their specific patient, who might be from an underrepresented group in the training data.
So they know its limitations.
Right. And there's something called shadow deployment.
Shadow deployment.
Yeah, you run the model in a live clinical setting, it makes its predictions, but those predictions don't actually get used for patient care. It runs in the background.
Why do that?
To assess how well it's calibrated in the real world, see how users interact with it, find potential problems before it impacts patients. It's like a final dress rehearsal.
Okay, that makes sense. And finally, post-deployment surveillance. That's the ongoing part.
Absolutely. This isn't fire and forget. It's a lifelong process. AI models need constant monitoring of their performance in the real world. They need maintenance, updates, recalibration as things change.
Is this formally required?
Increasingly, yes. The FDA, for example, has a framework for AML-based software as a medical device, SAMD, that mandates tracking real-world performance specifically to identify biases that might emerge after deployment.
So regulation's catching up.
It's starting to.
Yeah.
And healthcare institutions themselves need to stay vigilant, be aware of changes in their local patient populations or clinical practices that might affect how the AI performs.
That's a really comprehensive set of strategies covering the whole life cycle. It's clear it's a massive undertaking, but also that there are ways to tackle this.
There are. It's complex, definitely multi-layered, but the commitment to fairness is growing.
So looking ahead, what are the big picture steps needed to build this more equitable AI future in healthcare?
Well, first, there's just an immediate need to really meaningfully integrate those DEI principles across all the phases we discussed. It can't be an afterthought.
Make it standard practice.
Exactly. Second, we need to actively educate and train a more diverse and representative AI developer community. The people building these tools should reflect the populations they serve.
Broaden the talent pool.
Third, we need to expand programs within healthcare institutions themselves that focus specifically on assessing and monitoring these AI models. Build that internal capacity for oversight.
Okay.
And finally, a really critical piece. We need to integrate AI and machine learning content into medical training curricula for doctors, nurses, everyone.
Why is that so important?
Because healthcare professionals need to be prepared for this future. Data-driven decision-making is becoming standard. They need to understand how these tools work, their limitations, how to interpret their outputs, and how to contribute to making them better and safer. They need to be informed partners in this.
So they're not just passive users, but active participants in its ethical use.
Precisely. Ultimately, it requires coordination. Policymakers, clinicians, researchers, patient advocacy groups, everyone needs to work together to boost diversity and fairness in healthcare AI.
Wow. This has been an incredibly thorough and honestly eye-opening deep dive. We've really seen how bias isn't just one thing, but can weave its way through the entire process from our own minds right down to the code, making critical decisions.
And it's so vital to remember, recognizing this bias, actively working to mitigate it. It's not just about making the AI better in a technical sense. It's not just about accuracy.
It's more fundamental.
It's fundamental to upholding the ethical promises of healthcare. It's about making absolutely sure that AI becomes a tool that truly bridges gaps in care instead of accidentally making them wider.
Thank you so much for walking us through all of that.
My pleasure. And as you, our listener, reflect on everything we've talked about today, maybe consider this thought. How can we, both as individuals and collectively as a society, really ensure that as AI becomes more and more integrated into our health journeys, it genuinely serves everyone? How do we stop it from just perpetuating the inequities we already have? What role can each of us play, whether it's advocating, learning, or even building, to shape a future where AI truly serves all of us in healthcare?